In this video, we are going to learn about classification of inherited ataxias. This is a very important topic, not just in clinical practice, but in theory and as well as entrance exams. Various entrance exams have asked many questions on these topics. I have taken important points from Harrison's internal medicine as well as Braddley's neurology. So let us go to the topic per se. You can classify the inherited ataxias into autosomal dominant, autosomal recessive, X-linked and mitochondrial inherited ataxias. Let us see one by one now. Autosomal dominant ataxias. What are those? The most common type of autosomal dominant ataxia is the spinocerebellar ataxia. Next we have DRPLA, means dentatorubropallidoleucian atrophy. Dentatorubropallidoleucian atrophy. Next we have episodic ataxia type 1 to 7. These are the three important autosomal ataxias which you should know. What are those? Spinocerebellar ataxia, DRPLA, which stands for dentatorubropallidoleucian atrophy, then episodic ataxia type 1 to 7. Autosomal recessive ataxias, classical one is the Friedreich's ataxia. Friedreich's ataxia, then ataxia telangiectasia, then ataxia with vitamin E deficiency. Then we have CANVAS. CANVAS stands for cerebellar ataxia, here vestibular ataxia, N for neuropathy and S for syndrome. So we have cerebellar ataxia, neuropathy and vestibular ataxia syndrome. Next we have SPG7 syndrome, that is spastic paraplegia 7. Usually this spastic paraplegia causes what type of neurological problem? It causes just spastic paraplegia, but sometimes SPG7 can be associated with ataxia. That's why it is included under autosomal recessive ataxia. Next we have ARSAX. ARSAX stands for autosomal recessive spastic ataxia of C stands for Charlie Walks Sagveni. Okay, Charlie Walks Sagveni. So I'll repeat. ARSAC stands for autosomal recessive spastic ataxia of Charlie Walks Sagveni. Okay, then we have ataxia with oculomotor apraxia type 1 and type 2. Ataxia with oculomotor apraxia type 1 and type 2. Then there is ARCA1. ARCA1 stands for autosomal recessive cerebellar ataxia 1. Autosomal recessive cerebellar ataxia 1. If you see Harrison, he has given only these things. One is Friedreich's ataxia, ataxia telangiectasia, ataxia with vitamin E deficiency. If you remember these three, that is more than enough. But if you see Braddley neurology textbook, he has given extra syndromes like CANVAS syndrome. As I told, it stands for cerebellar ataxia, neuropathy, vestibular ataxia syndrome. Then SPG7, ARSAX, which stands for autosomal recessive spastic ataxia of Charlie Walks Sagveni. Then we have ataxia with oculomotor apraxia type 1 and type 2. Then ARCA1, which stands for autosomal recessive cerebellar ataxia type 1. And also you can include some other types of ataxia also, like Niemann-Pick disease type C, then CTX, that is cerebrotendinosis. Okay, so we have Niemann-Pick disease type C and CTX also, which are included under autosomal recessive ones. Now let us see X-linked ones. X-linked ones, classically it includes FX-TAS. FX-TAS means fragile X associated tremor ataxia syndrome. Okay, so FX stands for Fragile X associated tremor ataxia syndrome. Then we have something called Pelizaeus-Merzbacher syndrome. Okay, cerebral Pelizaeus-Merzbacher syndrome. Then we have adrenoleukodystrophy, which is due to ABCD1 gene. Okay, in entrance exam they will ask what is the gene associated with adrenoleukodystrophy? It is the ABCD1 gene. Then Pelizaeus-Merzbacher syndrome, it is nothing but one type of hereditary spastic paraplegia. Then FX stands for Fragile X associated tremor ataxia syndrome. These are the X-linked inherited ataxias. What are the mitochondrial inherited ataxias? Which includes NARP syndrome, MRF syndrome. Then we have coenzyme Q10 deficiency. Okay, so NARP syndrome stands for neuropathy, ataxia, and retinitis pigmentosa. Neuropathy, ataxia, and retinitis pigmentosa. This was one of the questions which was asked in the previous entrance exam. MRF stands for mitochondrial encephalopathy with ragged red fibers. So this is also one mitochondrially inherited ataxia. Coenzyme Q deficiency also causes mitochondrial inherited ataxia. So this is the broad overview of inherited ataxias. So you should know, importantly, what you should know is that the most common ataxia, inherited ataxia among all, is the spinocerebellar ataxia. It belongs to autosomal dominant one, and other autosomal dominant ones include DRPLA, episodic ataxia type 1 to 7. So in this class, in this video, what I am going to focus is mainly on the spinocerebellar ataxia, because a lot of questions are asked on this topic. Spinocerebellar ataxia, there are 1 to 48 types. These numbers are given based on the order of discovery of the genes. Okay, so 1 to 48, if somebody asks you how it is named, it is based on the order of discovery of genes associated with the disease. So there are some types which are deleted because of new pathology is found or new syndrome is given to that. So that's why some of the types of spinocerebellar ataxia are removed from the list. So right now what we have is the 43 spinocerebellar ataxia types. Actually numbers are 1 to 48, but since some of the types are deleted, we have 43 types now. Okay, so if you look into the genetics of spinocerebellar ataxia, you can classify the genetic pathology into repeat nucleotide pathology, number one. Number two, non-repeat pathology. What do you mean by repeat nucleotides? Means you have a nucleotide sequence like adenosine, guanine, cytosine, thymidine, like that, and those sequences, particular sequences, can get repeated multiple times, leading to gain of function mutation. Like suppose, for example, CAG is the commonly found triplet repeat nucleotide. CAG codes for glutamine. So when there is multiple copies of CAG in a gene sequence in a chromosome, what will happen is there are multiple um, glutamines produced that are called as polyglutamines, and these polyglutamines are toxic to the neurons, especially the cerebellar neurons, and that can cause cerebellar ataxia, like that. So accumulation of these repeat nucleotides can lead to toxicity to the neurons, leading to death of the neurons gradually, or degeneration of the neurons gradually. So another pathology is the non-repeat pathology. We will see that later. So among the repeat nucleotide ones, we have repetition of 3 nucleotides, that's called as trinucleotide repeat pathologies, then pentanucleotide and hexanucleotide pathologies. Trinucleotide pathology can be due to CAG repeats, that is cytosine, adenosine and guanine, or it can be due to CTG, which is cytosine, thymidine and guanine repeats. So if you see CAG repeat associated syndromes or the spinocerebellar ataxias, you can see that the spinocerebellar ataxias SCA 1, 2, 3, then 6, 7, 17, they are all associated with CAG repeats. I will repeat. As I told earlier, how many types of SCA we have? 1 to 48. In that, some are deleted. So we have right now 43 ataxias now, 43 SCAs. In that SCA 1, 2, 3, 6, 7, 17, they are associated with CAG repeats. They will ask in the exam. CTG repeat is seen in SCA 8. So SCA 8 is the only spinocerebellar ataxia which is associated with CTG trinucleotide repeats. Otherwise, majority are due to CAG repeats. So some of the SCAs are associated with pentanucleotide, means 5 nucleotide repeats. Like for example, SCA 10, 31 and 37. SCA 10, 31, 37, they are pentanucleotide repeats. What do you mean by penta? 5 nucleotides. For example, it can be ATT, CT, like that. So this penta nucleotides will get repeated multiple times. Okay. Next, hexanucleotide repeat. Here 6 nucleotides will be there. The only SCA under this is the SCA 36. Okay. So I will repeat now. The genetic pathology in spinocerebellar ataxia can be repeat nucleotide repeat disorder or non-repeat pathology. Under repeat nucleotides, we have trinucleotides, pentanucleotides and hexanucleotides. Under trinucleotides, we have CAG repeats, CTG repeats. See, there are many other conditions which are associated with other trinucleotide repeat sequences like GCN repeats, or it can be many other repeats which I am not covered in this section because we are talking only about spinocerebellar ataxia, not about other conditions. So, in spinocerebellar ataxia SCA, the CAG repeat ones are SCA 1, SCA 2, 3, 6, 7, 17. The CTG repeat ones are the SCA 8. This is the only SCA with the CTG repeat. So what are the SCAs with pentanucleotide repeats? SCA 10, 31, 37. Okay. Hexanucleotide, the only hexanucleotide associated spinocerebellar ataxia is the SCA 36. Remember this. Okay. In the exam, they will ask which is the only condition which is associated with tetranucleotide. So that is DM2. Tetranucleotide is DM2. DM2 stands for myotonic dystrophy type 2. That is the only condition which is associated with the tetranucleotide repeat sequences. Okay. So what is the nucleotide here? CCTG. CCTG. Okay. What about myotonic dystrophy type 1? So I told this is myotonic dystrophy type 2. DM2 means myotonic dystrophy type 2. What about myotonic dystrophy type 1? It's a trinucleotide which is associated with the CTG repeats. I know this may be a little bit confusing for you, but if you write down on your own and try to revise, it will be easy. So CTG repeats are seen in myotonic dystrophy type 1. Okay. So if they ask what is the type of myotonic dystrophy associated with tetranucleotide repeat sequences, that is DM2. With the trinucleotide one is the DM1. Okay. Next, coming to the non-repeat pathologies. Under non-repeat pathologies, we have point mutations, deletions, translocations and duplications. Okay, these are the non-repeat pathologies. So under the point mutation, we have SCA 5, which is a point mutation one. Under deletions, we have SCA 15/16. They have clubbed together, 15 and 16 together. SCA 14. Under translocation, we have SCA 27. Under duplication, we have SCA 20. It is very difficult to remember all these things, but just try to remember that among the non-repeat ones, SCA 5 is of very important in terms of examination, because see, there is a phenomenon of anticipation. All of you must be knowing. Anticipation means with each subsequent generations, the onset of the disease will become much earlier. So as there is subsequent inheritance to the subsequent family members, it gets manifested much earlier. That phenomena of anticipation is seen with all these repeat nucleotide pathologies. One exception is the SCA5. This is the only condition with a point mutation or with a non-repeat nucleotide pathology which has got phenomena of anticipation. So SCA5 is the only non-repeat condition with the phenomena of anticipation. I hope this is clear. Okay. Now in the exam they will ask about, they may ask in multiple angles. What I told is only with respect to the spinocerebellar ataxia till now. Now in general all the neurological disorders we'll try to see. What are the neurological disorders with CAG repeats? One, I've already told that it is SCA 1, 2, 3, 6, 7 and 17. Then DRPLA. What is DRPLA? It is dentatorubropallidoleucine atrophy. That's also CAG repeat only. Then we have Huntington's disease. Huntington's disease. Then SBMA means spinobulbar muscular atrophy. It's a type of MND. It's called spinobulbar muscular atrophy. Then we have HDL2 means Huntington disease like 2. HDL2 means Huntington disease like 2. So what are the CAG repeat disorders? CAG triplet nucleotide disorders, SCA, in that SCA 1, 2, 3, 6, 7, 17. Then DRPLA, which is also autosomal dominant ataxia. Then HD, Huntington disease. SBMA is spinobulbar muscular atrophy. Then Huntington disease like 2. Next, what are the CTG repeat disorders? So which type of SCA will have CTG repeat disorder? Can you tell me? I've already told SCA8 is the only spinocerebellar ataxia with a CTG trinucleotide repeat disorder. Next we have HDL2, that is Huntington disease like 2. So this can have, HDL2 can have CAG repeats as well as CTG repeats. Okay, next we have myotonic dystrophy type 1. I told already, myotonic dystrophy type 1 has got CTG repeats. Whereas myotonic dystrophy type 2 will have what? Will have CCTG repeats, that is tetranucleotide. So the only tetranucleotide repeat disorder in neurology is myotonic dystrophy type 2. So this is a potential question which can be asked in the entrance exam. Next, what are the conditions with GAA repeats? One is Friedreich's ataxia, then SCA50. SCA50. This is given in some articles, but I don't know what is the authenticity of the information. So you can remember only Friedreich's ataxia as the answer for this. GAA repeat. Okay, CGG repeats. Where do you see this? It is seen with the Fragile X syndrome. Fragile X syndrome. Okay, then you can also see in FX-TAS. FX-TAS, FXS, that is Fragile X syndrome. Then there is something called FXPOI. FXPOI. Okay, so FXS is Fragile X syndrome, whereas FX-TAS is Fragile X associated tremor ataxia syndrome. FXPOI stands for Fragile X associated primary ovarian insufficiency. Okay, so these are the CGG repeat ones. What is the gene associated with this? This can be asked in the exam again. FMR1 gene. FMR1 gene, remember this. So FMR1 gene is common for all this: Fragile X syndrome, FX-TAS, FXPOA, like that. So classically the Fragile X syndrome, the typical faces will be like long face, long jaw will be there, very large ears will be there, then eye arched palate will be there, macrocephaly, orchidism means macro testis will be there, then Prader-Willi phenotypes. They basically they are obese with big organs like long face, large ears, high arched palate, macrocephaly, obesity, macroorchidism, like that. Along with that, they have neurological problems like mental retardation, autism, and ADHD, attention deficit hyperactive. Attention deficit hyperactive disorder. Okay, this is the classical presentation of Fragile X syndrome. Okay, if Fragile X syndrome is associated with tremor ataxia, then it's called FX stars. Okay, if it is associated with primary ovarian insufficiency, then it's called POI. Okay, I think this should be clear. Next, GCN repeats. Where do you see this GCN repeats? This GCN repeat is seen in classically one neurological condition that's called OPMD. OPMD stands for oculopharyngeal muscular dystrophy. Oculopharyngeal muscular dystrophy. What is the specialty of this muscular dystrophy? This is one type of muscular dystrophy which can present very late. Like it can be present in the elderly. That may be the first time when they start noticing the symptom. Among all the muscular dystrophies, they're all either in the first decade, second decade, or third decade, but this can go up to sixth, seventh decade also. And usual presentation will be they will have dysphagia, ptosis, like that. That's why it's called oculopharyngeal muscular dystrophy. Okay, so in the entrance exam, if they ask which is the muscular dystrophy which with a very late onset, is OPMD. And what is the problem there? GCN repeats. GCN repeat sequences. It's a triplet nucleotide repeat disorder. So other GCN repeat disorders includes, then we have many other conditions like congenital central hypoventilation syndrome. Congenital central hypoventilation syndrome. Then we have holoprosencephaly. Holoprosencephaly. Then X-linked mental retardation. Then hand-foot genitalia syndrome. Okay, next, what are the pentanucleotide repeat disorders? Can you tell me which type of SCA will have pentanucleotide repeat disorder? Three are there. What are those? SCA 10, 31, and 37. Then we have CANVAS. CANVAS belongs to autosomal dominant or recessive? Yes, autosomal recessive. And it stands for what? Cerebellar ataxia, neuropathy, vestibular ataxia syndrome. Then we have FAME. FAME means familial adult myoclonic epilepsies. Familial adult myoclonic epilepsies. Okay, so these are the three conditions with the pentanucleotide ones. So MCQs can be like which type of SCA will have pentanucleotide? Options can be SCA 1, 3, 7, 17, 10, like that. So you should remember the SCA 10, 31, 37. Then CANVAS, which is autosomal recessive inherited ataxia. FAME is not related to ataxia, but it is associated with myoclonic epilepsy. I've included here all the neurological conditions with these repeat disorder, not just ataxias. Okay. Next, hexanucleotide 6. Which type of SCA will have hexanucleotide repeat disorder? SCA 36. This is the only spinocerebellar ataxia with the hexanucleotide repeat disorder. Then some FTD, that is frontotemporal dementia, and ALS complex can have hexanucleotide repeat disorder. Okay. So that is about few important MCQs that might be asked in the entrance exam. Then classification system of spinocerebellar ataxia. We have numerical classification system. Numerical one, which is I told earlier 1 to 48 based on the order of discovery of the gene. Then Anita Harding's classification. This is one classification. This classification actually has got three groups, that is ADCA 1, autosomal dominant cerebral ataxia 1, ADCA 2, ADCA 3. So three groups are there. ADCA means autosomal dominant cerebellar ataxia. Okay, so in that you can't remember everything. So what you can remember is under ADCA 2 group only SCA 7 is included. So remember this, that is enough. Okay, Harding's classifications, only SCA7 will be included here. Okay, next we have MDS system. MDS means Movement Disorder Society system of classification of cerebellar ataxias. So here it is based on the genes, it is still evolving, so you don't have to remember this. Here what they are proposing is that we have to give a prefix ATX for ataxia and then the gene which is associated with it, like ATN1 gene, like that. It can be ATN1 gene, DAB gene, uh, SNAP25, TUB2A, like that. Multiple genes are there. You can add based on the gene that is there. So what is the most common type of spinocerebellar ataxia worldwide? Is the SCA3. That is the most common type. SCA3 stands for Machado, or it's also called Machado-Joseph disease. Machado-Joseph disease. What is the classical presentation of unique feature of this one is the dystonia. They will have ataxia, spinocerebellar ataxia, along with dystonia. This one point you can remember very well. Means many others associated signs are there, but dystonia is very peculiar to Machado-Joseph disease. Then what is the most common type of SCA in India is the SCA2. SCA2. But if you see Braddley textbook of neurology, he mentions SCA12. So I'm not sure whether to take SCA12 as the most common type or SCA2 as the most common type. But one thing is that SCA2, much of the contribution is given by Indian neurologist Dr. Wadia. That's why it's also called as Wadia type of ataxia. So it's also called Wadia ataxia. And what is the classical presentation of this SCA2 is the slow saccades. It's a very unique feature. And why there will be slow saccades? Because of the involvement of there is something called excitatory burst neurons in the caudal pons. So there is a degeneration of neurons called excitatory burst neurons, which are responsible for the saccadic movement of the eyes. So because those cells are dead here, that will result in slow saccades. So what is the most common type worldwide is the SCA3. It's also called Machado-Joseph disease. Peculiar feature is the dystonia. Then in India, most common is the SCA2, because it is very well described by Dr. Vadia. It's called Vadia type of ataxia. And characteristic feature is the slow saccades. Why there is slow saccades? Because of the caudal pons involvement. Okay. So DRPLA is dentatorubropallidoleucian atrophy. Here the gene that is associated is the atrophin-1 gene. Atrophin-1 gene, also called ATN1 gene. What is the chromosome? Chromosome 12. What is the pathology? Is CAG repeats, triplet nucleotide repeats, and it is autosomal dominant or recessive? It is autosomal dominant. In the first classification only I told it's autosomal dominant type. Anticipation is there or not? Yes, all triplet nucleotide disorders will have anticipation, phenomena of anticipation, it is there. Okay. Also, okay, what are the other names given to this DRPLA? It's also called as NATO Oyanagi disease. NATO Oyanagi disease, also called as Ha River. It's also called Ha River syndrome. Okay, so two synonyms to DRPLA, that is NATO Oyanagi disease, Ha River syndrome. What are the 5 cardinal features of DRPLA? Is the ataxia. So that is the first thing, no, because we included this under classification of inherited ataxia. So you should remember that the one of the cardinal feature is the ataxia. Then we have cognitive decline, then chorea, epilepsy, then myoclonus. Okay, so these are the 5 cardinal features of DRPLA: ataxia, cognitive decline, chorea, epilepsy, and myoclonus. So there are 3 forms of DRPLA. One form is called the juvenile form. Juvenile age will be less than 20 years. Then we have early adult form, 20 to 40 years of onset. Then late adult form, that is more than 40 years. Okay, so if one thing you should remember is that the younger the onset, that is juvenile form, has got more seizures. They are more of epileptic patients and less of ataxia, whereas the later the onset, more of ataxia will be there. Okay, so less seizure and more ataxia is seen in late onset DRPLA. Juvenile one will have more seizures and less ataxia. If you see MRI, what will be there in MRI? There will be cerebellar atrophy because it's a cerebellar pathology. Dentato-rubro-pallido-leucian atrophy. Dentito, why it's called dentito? Because it involves the dentate nucleus in the cerebellum. Rubro because rubral red nucleus will be involved. Okay. Then we have brainstem atrophy also, because brainstem atrophy because the red nucleus and other associated structures will be involved. Then along with that, white matter also will show some changes. This is the reason why white matter changes is the reason why they can have cognitive decline. Okay, one of the cardinal feature I told earlier, that cognitive decline, chorea, epilepsy, myoclonus, all these things are there. Cognitive decline is because of the white matter involvement. So the treatment for this is treatment of seizures with carbamazepine, that is a drug of choice. Then you can give riluzole. It's a free radical scavenger. Where it is given classically MCQ, it's given in MND, motor neuron disease, but this can be tried even in DRPLA. So this is in broad about inherited ataxias. What I've covered is classification of inherited ataxias. Then I have told important MCQ related points about spinocerebellar ataxia. Then in general in neurology, what are the trinucleotide repeat disorders, what are the tetranucleotide repeat disorders, pentanucleotide, hexanucleotide repeat disorders, like that. And then I have covered various classification systems of spinocerebellar ataxia, then which is the most common type of SCA worldwide as well as in India, and what are their peculiar features. Then lastly about DRPLA. So in that DRPLA, what are the 3 forms? MRI, abnormality, carbamazepine is the drug of choice. All those things I have covered here in this. Okay, so I hope this video is informative and helpful in your theory as well as entrance exam. Thank you.